Good evening, everybody. My name's Vicki Atkinson, and I'm glad to welcome you here tonight for our second happy hour. And it's not as bright and light as it was a few weeks ago, so winter is creeping in on us. For some reason, we have the most hilarious situation here. We have about 7 Emmanuel Petersons who have joined. So if your name isn't Emmanuel Peterson and you want to answer a question, will you please put your real name there, because we'll have to call you Clone 1, Clone 2, Clone 3. Anyhow, so on behalf of all of us, we'd like to welcome you. This is an informal meeting today, and we want it to be that way, respectful, but also informal, to ask some of the really tough questions that we need to answer. And so that's where we are. Today, our hosts are, we'll start from one side to the other in my head, is the National Institute of Communicable Diseases, who has co-hosted these events with us, and we're very grateful for at least 3 of the staff members here tonight. And it's been very popular on the other side of it all when we put up the YouTube. And the other host is the Department of Health, the Human Sciences Research Council, and also Cancer, who is our communications partner that do a lot of the, help us with a lot of the work, and Emmanuel Peterson Digital, who is behind the scenes recording and doing all the rest. He can pop out if he wants to, but he might not want to pop out because he's got him. There he is, saying, how's it to you all? Hi. Okay, so here's the, oh, it's just the dog. Goodness gracious.
It
well,
is
happy hour.
It's my co-host, called Caspian.
Okay, great. Well, that's good. So we have a whole, we're about to start. The format is that we take 15 minutes of in 2 parts. We have 15 minutes of a presentation by Waasila this time, and then 15 minutes of questions. And then we move on to the next second part, 15 minutes with Murray Dryden and his co-presenter, although she's decided not to present. Caroline is also here. And so Murray will do the presentation, followed by a discussion. If you want to make a comment or ask a question, we will put, would you please put it in the chat box? And so that will be really good so that we can have questions to answer. And then we are ready to start. So I'm going to, without further ado now, we need to get Waasila online. She is online and she can share her screen. And Waasila, hi there, Waasila.
Hi. Good
to see you back.
Thanks for having me again.
Oh, we don't have you. You have us in the palm of your hand. So Waasila, there is the slide. I'm going to leave it over to you. Waasila is a public health specialist at the National Institute of Communicable Diseases. She produces all of this data along with the team of people you can see, and Caroline Madara, she'll have to tell me how to say that, is part of this team as well. So she's very hard working behind the scenes. I'll leave it over to you. Thanks so much, Waasila.
Thank you so much. It's good to be with you again. So I presented the last time on some of the non-communicable disease data that we have we've been collecting through the DATCOV hospital surveillance system. And today I'll take some time to talk you through the trends we've seen in hospital admissions for COVID-19 in the first and second waves, and looking ahead to a possible or probable third wave. And just want to acknowledge my team at NCD who have contributed. So let's talk a little bit about what we've published recently on the first and second wave mortality. So what we noted in other countries, there's been a decrease in case fatality ratio, since early in the epidemic last year. And in most countries, they've reported a lower case fatality ratio in the second wave than they did in the first wave. In South Africa, on the other hand, the mortality has been increasing, and we noted higher case fatality ratio in the more recent months. So the literature suggests that the case fatality ratio has been lower globally in the second wave, while there's higher numbers of cases, death rates have been lower. And some of the reasons for this is because the demographic characteristics of the cases may have changed. They may be younger people with less comorbidities. Many of the elderly and those with health conditions who are vulnerable are likely to have died in the first wave, so that there's a sort of cohort or harvest effect, and those people were not around in the second wave. In addition, the healthcare systems have improved and testing capacities have improved in the second wave, so that more people are identified with COVID-19 as time goes on. The health systems are also better able to treat patients with severe disease, and we have more interventions that we know work, such as steroids and antivirals and high-flow oxygen, prone positioning. And so some of these are all thought to have decreased mortality, after the initial period of the epidemic. They also think that wearing of masks and social distancing reduces the viral inoculum, and that causes less severe disease. So also, what we do know is that mortality is associated with hospital capacity. And we know this before COVID. In non-pandemic settings, when there's a strain on hospital capacity, there's increased mortality. But studies during the era of COVID-19 have shown that mortality in hospitals are higher when the community incidence of COVID-19 was high or increasing. Other studies have shown that case fatality is higher when the number of hospitalizations are highest and when there is a rapid increase in admissions. And particularly a strain in critical care capacity, ICU beds, etc., are associated with a nearly twofold increase in COVID mortality compared to those times when there's lower demand for critical care beds. The other factor for South Africa is the identification or the emergence of the new variant in September, October last year. So you can see our first and second wave of cases in gray, admissions in green, and deaths in blue. And you can see that the second wave had a higher number of cases, admissions, and deaths. And what you can see below that is the timing of the appearance of the new variant in yellow. When it appeared in late September, it soon became the predominant lineage. And from around November, December, it was the most commonly sequenced lineage. So when we look at mortality ratio in the DATGov data per month, we see that the case fatality ratio from March last year increases until the peak of the first wave. It drops again. And then as the second wave starts, it increases again until the peak of the second wave in January, and then drops again. So you can see that mortality increases at the peak of the wave, and that it was higher in the second wave than it was in the first wave. So we did this analysis of the DATGov National Hospital Surveillance System. We looked at data from 5th March 2020 to 6th February 2021. DATGov now has coverage of all public and private hospitals, and at the time that we did this analysis, it reported over 200,000 admissions and over 43,000 deaths. So this is the curve of hospital admissions, and we determined the wave period using the incidence for admissions. And so the start to the end of the first wave, we had 73,868 admissions. We then had a pre-wave 2 period. And during wave 2, we had 95,784 admissions. So we do a multivariable analysis of factors associated with mortality among patients who are hospitalized. And as I showed you the last time, we know that age, sex, race, and comorbid conditions, as well as the health sector you're admitted in, all have an association with mortality. But what I wanted to show you is blocked in red below. So when you compare mortality in the wave periods, you'll see that in pre-wave 1, mortality was roughly 18%. During wave 1, 20%. It dropped in pre-wave 2 to 17%. And in wave 2 was 27%. And so what you can see in the column on the right is the adjusted odds ratio of 1.4, and that means a 40% higher risk of mortality in wave 2 than in wave 1. But because we know that hospital load also has a bearing, we include weekly admissions in the model. So you can see at the bottom, when there are low numbers of admissions, less than 3,500 per week in the country, the mortality is 18%. When there are medium numbers of admissions, 3,500 to 7,999, the mortality is 21%. In weeks with high numbers of admission, 18,000 to 12,499, mortality is 24%. And in weeks with very high admissions, over 12,500, mortality is almost 30%. And so you can see on the right that there's a 50% increase in mortality in weeks with very high admissions compared to weeks with low admissions. And when you add a weekly load of admissions to the model, it changes the mortality estimate. And you can see now that there's a 20% increased mortality in wave 2 compared to wave 1 after adjusting for the load of admissions. And so what our data is showing is that there is a 20% increase in in-hospital case fatality ratio in the second wave when the new lineage was dominant. And also what we're seeing is that weekly COVID-19 hospitalization load is associated with mortality. Now, there's a lot of limitations with ecological analysis like this. We do not account for certain things, such as the service volumes in the hospitals for non-COVID admissions. We only included COVID admission loads. There could also be a reporting bias where some hospitals, have not fully reported. We couldn't account for the levels of national restrictions and individual preventive behaviors, which may have changed from last year to this year. We couldn't account for the change in testing practices and the thresholds for hospitalization, which may change, and also the changes in treatment protocols since March last year. And I think ideally to do a study looking at whether the variant is associated with mortality, you would need to have individual level data on sequencing on every case, and that's wasn't possible. And so we used this kind of ecological analysis to look at the trend in mortality in the second wave compared to the first wave. And we know that the old lineages predominated in the first wave, and the new lineage 501YB2 in the second wave. And so we make a tentative conclusion that this residual increased mortality is likely associated with the new variant. So on to talking about the third wave, and first looking at evidence from other countries. From an analysis done a few weeks ago, we knew that 17 countries had ended their second wave and 4 countries had entered their third wave. And just a couple of examples, Israel and Serbia, you can see that each wave has been successively bigger and that each wave followed relaxation of restrictions. More recent data in India, France, Turkey, and Poland have shown quite significant increases in their third waves already. So what are some of the factors that might drive a new wave? The one would be behavior change and an increasing level of contacts. So the graph I've shown you is the hospital admissions, the weekly incidence of cases of COVID-19 in the country. And that's per province. And you can see the first wave and the second wave, and you can see low levels in most provinces post second wave, but you can see a blip in brown, which is some cases in the Northern Cape. And when you look at the Northern Cape epi curve in more detail, you can see that those cases appeared about 2 or 3 weeks ago. Particularly in the younger age groups, you can see a blip in the 5 to 9 years, 10 to 14 years, and 15 to 19 years. And so this was, related to outbreaks in the school settings in the Northern Cape, and they have since settled. In the media, we've heard also in the last week outbreaks amongst university students in Tshwane. And so, we already are seeing some small outbreaks, even though we are in the post-wave period, and we are watching for any signs of increase of transmission. And so the behavior change could come from a few things, and the increased transmission could come from a few things. There could be reduced adherence to infection prevention and control measures, such as masking and hand hygiene. There could be reduced adherence to other non-pharmaceutical interventions, such as social distancing. And with the easing of restrictions post-wave 2, with holiday travel over April, Easter holidays, and with super spreader events such as funerals and weddings. I think these are likely to drive a third wave. We know that a resurgence in transmission driven by behavior change is likely to affect communities that had a relatively low level of transmission to date, and that areas that experience large epidemics in the first and second waves may be less affected by a third wave driven by behavior change. Another factor is seroprevalence. So you may have seen some studies released in the last few months of seroprevalence across the country. And what we're seeing is substantial variation in the seroprevalence in different communities and settings. We see it differ across provinces, differ across urban and rural areas. And there are also associations with indicators of race and socioeconomic factors. And so what we believe is that some communities may remain very vulnerable with a high risk of community level transmission as their contact levels increase. So seroprevalence is the second thing that may drive a third wave, particularly in areas that have not reached a very high seroprevalence. The third factor is further viral mutation. And so the graphic shows you the different lineages that have been predominating in South Africa. And what you can see in the green is that the 501YB2 or B1351 as it's called appeared in sort of September, October, and then became the predominant lineage. And so we have no idea about the emergence of new variants and what the effect of those might be. Another factor to bear in mind is the level of vaccination. So we know that in South Africa, currently, we only have vaccine administration through the Johnson & Johnson phase 3B clinical trial, which is primarily given to healthcare workers. So we don't yet have confirmed timelines for acquisition and rollout of COVID-19 vaccinations. And currently, as of the 6th of April, we had just over 270,000 vaccines administered. So it's unlikely that the COVID-19 vaccine will have a substantial effect until later this year and would not be a factor to prevent or mitigate against a third wave. There are a couple of other factors to bear in mind. Waning immunity. So we know that once you've had COVID-19, you develop some immunity, and by all accounts, this lasts for a few months, as we see with other coronaviruses. And we are seeing some reinfections occurring in individuals who had contacted SARS-CoV-2, although it appears to be rare. But waning immunity may be a gradual increase in population level susceptibility. There have been theories around seasonal factors, but it's unlikely that seasonal factors will play a big role in driving transmission of SARS-CoV-2. So finally, just to say that given all those factors, it's unlikely to predict when a third wave would occur. Given that many European countries have entered the third wave and that it's a large wave, it's something that we're monitoring for quite closely. I think that our control measures around restrictions, especially during the April holidays, would be quite important. But this is something that the national control councils are looking at very closely. And we are looking, so this is one of the graphics from the modeling consortium, and we look at across districts any upticks or upswings in admissions. You can see in red the few little outbreaks in the Northern Cape and in Free State, but those have all settled. So we'll continue to watch these to note if there's any sustained increase in transmission, which may indicate that we're entering a third wave. So unfortunately, difficult to predict when that might be, but I just wanted to share with you some of the factors that may be responsible for driving the emergence of the third wave and how we are monitoring for this. We are also doing some studies to better prepare the hospitals ahead of the third wave, looking particularly at the hospitals that had high mortality in the first and second wave, so we can better prepare them to cope and have better surge capacity ahead of the third wave. Thank you. That's all for me. Happy to take some questions.
Hi, Waasila. Can you put your picture back on, your own video? There you are. So that's great. We don't have any questions at the moment. I think it's probably because maybe like me, I'm absorbing it all in one fell swoop. And I wondered if I could ask you some questions because I'm a little bit lost with some of that. Is that all right?
Sure.
Okay, so what if you just had to tell us all of that to us in plain English? Is that wave 1 was different from wave 2, and just say very shortly how wave 1 was different from wave 2, and that wave 3, when it comes, I'm not as optimistic as you thinking it won't come. I'm asking, when wave 3 comes, what can we do differently to either stop it, slow it down, or whatever? So if could you help me with that?
Sure. So in South Africa, we had very high level restrictions in wave 1, which slowed down the onset of our wave 1, I think, for a few weeks, and helped us to better prepare capacity in the hospitals and testing capacity to manage when the wave did come. Conversely, in wave 2, we had much looser restrictions. And so we had a very rapid increase in cases, and a much higher peak in cases in wave 2. Whereas in other countries, I think they had higher levels of restrictions in wave 2. So what we saw in South Africa was that, you know, most districts and most provinces were affected more significantly in wave 2 than they were in wave 1. So there were higher levels of cases, admissions, and deaths in wave 2. And when we look at the excess mortality data from the MRC, we can see that the mortality and probably the cases were much more in excess than what we are even reporting. So I think that the important things are that you know, we need to slow down transmission so that we don't have a rapid increase in cases, because that's when the hospitals don't cope. If we have restrictions at the start of the wave, I mean, it will come. If we have restrictions and better sort of personal preventive behavior from individuals, we can have a slower rate of increase. And a slower rate of increase means we have a slower rate of increase in admissions to hospitals, and the hospitals are better able to cope with the load. And I think that's really important. And so, you know, the lessons ahead of the third wave is that it's likely to come. It's likely to be bigger than the first two waves are, if the evidence from other countries is anything to go by. And, you know, I think what's important is how we prepare our hospital capacity and how we try to flatten the curve. I think that would be the most important intervention that we have, so we can better, you know, prepare or prevent mortality in the third wave.
Thanks so much. I've got appreciation from people for your presentation, and I'm also, so that puts it in a much clearer perspective. But what I also hear you saying is that by the blips that seem to have happened since the end of the second wave, when we stop social distancing and we get into more congregate settings, it's more likely to increase risk, you know, increase the transmission rate. You mentioned people going back to school, and I can't remember what the other one. One was the Northern Cape, and then there was universities. So it was schools and universities. What does that mean for us going forward?
I mean, I think that it's what we know and what we expect. You know, when the chances are higher, when there's fatigue and people, you know, drop their caution and start, you know, not social distancing and not using masking and hand sanitizing, we know that there's increased likelihood of transmission. We know that the April holidays are a huge risk for transmission as people gather together and go on holidays. We know that going back to school is always a risk for transmission as well. So, I mean, I think given those risks and given particularly the COVID fatigue that we see, you know, the fatigue people have experienced in terms of keeping up the public health and social distancing measures, I think that it's something to be aware of, and it's something for people to take individual action. It's something for continuous messaging to be out there to you know, advise people as best as possible how we can prevent the third wave from overwhelming hospital capacity. And I think it's you know, I think messaging particularly around gatherings are quite important right now. And of course, I mean, understanding who are high risk and making sure that they are better shielded and protected, knowing that mortality is highest in older people and in those with comorbidities, and knowing that they are unlikely to be vaccinated for a few months to come. I think that, particularly people who are high risk should take additional precautions to prevent transmission.
Thanks so much, Waasila. I have one question from you. Internationally, is there an average time lapse between waves?
I don't know if we've quantified it, but we know that that the second wave seemed to peak in December in many countries in Europe, and they've now kind of started a resurgence and a third wave. And so, that's about 3 months later, 3 or 4 months later. We know that the time between our first and second wave, the first wave ending at the end of August and the second wave starting around November, was also around 3 months. So, it's all very difficult to predict. Our modelers have got very sophisticated models looking at it, but it also depends on local measures. I mean, if there's really good high-level restrictions, you can potentially delay the onset of the wave. But yeah, I mean, I think that, considering about a 3-month period between waves is what we've seen locally and internationally.
Thanks so much, Waasila. So before I stop off on this last one, I've got again, thanks from Vimla Moodley, who's saying thank you so much. I'm sure she's heard you more than once, and each time she comes back for more. The point I would like to highlight to this group is that high-risk individuals need to keep paying attention. We don't have the privilege to be complacent. Is that what you're saying?
Absolutely. I mean, we can't take account for other people's behavior. And so we can only really be careful for us and for those around us, make sure that we're not a risk for others, and make sure that if we are high risk, that we do whatever we can do to avoid being infected.
And so I've got about 21 reasons why I'm at high risk. And so I'll be staying home and I'm very lucky to have a nice home to stay in for the next couple of months. Thanks so much, Waasila. Take care. Now we have Dr. Murray Dryden. If Murray would pop into our view stream and get his slides or presentation showing. Murray also works at the National Institute of Communicable Diseases, and he has specialized in one part of it called long COVID. And that long COVID, we've been hearing a lot about it, where the symptoms seem to last for a long time. And the question that I've also asked Murray to look at as well, how does it line up with chronic fatigue syndrome and with chronic fatigue syndrome, or as it used to be called, myeloencephalopathy. It's also used to be called, I think, yuppie flu. We have a whole number of people in the audience who are from that organization. Now, I can't see Murray, and I don't know if I'm not seeing Murray because he's not put his video on. Okay, just show us your face, please, Murray, so we can say, there you are, how's it? Okay, Murray's in Durban, and he's got stuck there because he had a horrible accident, and he's been stuck in Durban. What a terrible place to get stuck, Murray.
Oh no, it's been absolutely shocking on the beach.
Thanks so much, Murray. So we were looking forward to your presentation, and thank you for doing it despite all the things that go on a normal day. We look forward to your presentation, and after it, I will introduce this large contingent of people from the chronic fatigue syndrome group and the chair. Thank you so much. Look forward to it. Bye-bye.
Good evening, everyone. My name is Dr. Murray Dryden. I'm presenting on behalf of the NCD and the DATCOV team on post-acute sequelae of SARS-CoV-2 infection, or PASIX, which is formerly known as long COVID. So I'm just going to dive straight into it with some terminology so we all know what is going on. With regards to acute COVID, its signs signs and symptoms from up to 4 weeks from symptom onset, or ongoing symptomatic COVID, which occurs between 4 to 12 weeks, and post-COVID syndrome, which is symptoms which persist beyond 12 weeks. For long COVID, this over encapsulates between ongoing symptomatic COVID-19, so from 4 to 12 weeks, and then post-COVID syndrome, which is 12 weeks going forward. That being said, post-acute sequelae or SARS-CoV-2, which was formerly named by the NIH Director Francis Cran, is the persistence of signs and symptoms associated with COVID-19 beyond 4 weeks of acute illness, not better explained by another disease process. And these are terminology from the National Institute for Health and Care Excellence. With regards to the background of long COVID. So long haulers was a terminology that started popping up in articles as early as February of 2020. There were predominantly stories of patients reporting persistence of symptoms months after the initial diagnosis that was shared on blogs, Facebook groups, and other social media platforms. With regards to concerns, they were concerned whether these symptoms were results of an ongoing infection and whether they could infect other people. And initially, the medical response was rather poor. And I think that's primarily as a result of healthcare providers being focused on those who are acutely ill. So these are just some examples of COVID support groups, some of the websites that they had, Facebook groups, and some of the early articles that occurred online. And if we start looking at the actual medical literature that we have available online, if you go through PubMed and look at long haulers or long COVID or post-acute COVID, there are roughly about 2,000 results, if that. And if we look at COVID as a whole, it's over 100,000 records. So I think the important thing here is that we need more evidence, and particularly it needs to be relevant to the South African context and to our population. With regards to the causes of PASIX, what is currently thought is that it's a result of inflammation and injury that occurs during the acute infectious period. And these injuries can occur in a variety of organ systems, including the brain, heart, and of course the lungs, but ultimately it can occur in any organ throughout the body. The most important take-home message from anything that we're about to say tonight is that there's no ongoing SARS-CoV-2 infection. These patients are non-communicable. They're not going to pass it on to anyone else. And the most important thing is that they need help, and we are the ones that need to be responsible for that. So looking at risk factors for PASIX, about 10% of patients who have suffered from COVID-19 may be at risk for developing PASIX from COVID. Severity of acute COVID infection has not been shown to be a factor associated with the development of PASIX, and early data on at-risk groups have found that pre-existing depression is associated with severe post-COVID fatigue, and males are twice as common than females in developing PASIX, although there is some conflicting evidence in available research, and we may also need to consider health-seeking behavior between these sexes. The high BMI has also been found to be a significant risk factor associated with the development of PASIX, but further research on determining these important risk factors is important. With regards to the diagnosis of PASIX, there is currently no laboratory tests available that can be used to diagnose it, and antibiotic testing is not translatable in making this diagnosis. A PASIX diagnosis is primarily clinical in nature and on the basis of exclusion. So it is important to consider other conditions that may present in a similar manner, if not better. Currently, patients who were laboratory confirmed diagnosis of COVID-19 with persistent symptoms beyond 4 weeks of acute illness can be considered for a PASIX diagnosis. In addition, patients with COVID-like illness without a laboratory confirmed test, but persistent symptoms in keeping with acute COVID and PASIX should be considered as well. In terms of the presentation, the most common symptoms reported thus far are severe fatigue, shortness of breath, persistent cough, chest pain or heaviness, joint pain or swelling, whilst other symptoms that are also important and present commonly are cognitive impairment or brain fatigue, as well as muscle pain and headaches, while the syndrome is also often accompanied by anxiety, depression, which may be associated with a protracted and unpredictable course of these symptoms. So with regards to the NICD DATCOV long COVID or PASIX study, we have set up a quantitative longitudinal cohort with the purpose of establishing the presence of long-term complications of COVID-19 survivors and our ability to guide their rehabilitation. That being said, we would like to characterize the psychosocial consequences as well as physical consequences in patients with COVID-19 infection and estimate the risk of and risk factors for PASIX. We have received ethical approval from the University of Witwatersrand HERC, and we are proudly funded by the Bill and Melinda Gates Foundation. We are currently sampling patients who are hospitalized and subsequently discharged alive. We utilize the DATCOV hospital surveillance database to identify potential participants, and our research assistants and surveillance officers conduct a telephonic interview at 3, 6, 12-month periods using a CRF consisting of approximately 120 questions, looking at presenting symptoms, ongoing symptoms, quality of life tools, and changes in employment, as well as the ability to perform activities of daily living. With regards to our current enrollment, we have conducted over 4,000 calls since January 2021, with an enrollment rate of 24%, and the median time from discharge to first follow-up being 1 month. If we start looking at our sample population in regards to demographics, the median age of all of our participants is 52 years, with an almost equal distribution between male and female patients, whilst more than 80% of our patients are over the age of 40, and 51% of these participants being between the age group of 40 to 64. In terms of the breakdown of race, it is very similar to our DATCOV hospital surveillance data, with Africans being the highest number of enrolled persons, followed by whites, coloreds, and Indian population, with relatively equal distribution amongst sexes again. With regards to patients followed up in the study, nearly 60% presented with a history of high blood pressure, followed by type 2 diabetes, just above 30%, followed by HIV with 10%. These are the symptoms that patients have reported when they're admitted to hospital during the acute phase of the COVID-19 infection. As you can see, the most common symptom reported was fatigue and malaise, just above 60%, followed by shortness of breath, cough and fever, muscle aches, headache, chest pain, and joint pains. With regards to symptoms reported by patients at the first 1 month follow-up, shortness of breath again featured with nearly 65% of the total sample, followed by headache, muscle weakness, confusion or lack of concentration. These symptoms are in keeping with currently available literature, although we do feel that as our sample size increases, we will be able to better describe these findings in relation to other international studies. There are some international studies that have found a high prevalence of brain fog or confusion reported by these patients. And although fatigue and shortness of breath are still reported commonly amongst all symptoms in that regard. Once again, this is a table that comes from our previous figure of the most common symptoms amongst patients the 1 month follow-up with comparison between the male and female groups. Within shortness of breath, the results were similar between both males and females at 34%. Females reported a headache more often than males at 22.5% versus 16.4%. Muscle weakness was most common in males in comparison to females at 20% versus 18%. Confusion was reported more often in females than in males at 21% versus 16%. And interestingly, a persistent cough was a common feature amongst both populations at an average of 16%. Other common complaints included chest pain, sleeping problems at night, dizziness, and blurred vision. Of all the patients enrolled in our study thus far, a small number of patients at 54 reported severe complications. 7 patients had a history of heart attack. 2 patients had a history of deep vein thrombosis. 4 patients reported a history of stroke or mini stroke. 14 patients presented with a history of pulmonary embolism, and 26 patients reported a history of kidney problems. There was a slight predominance for kidney problems within the male population. Otherwise, there's no immediately apparent difference between the sexes within this category. In terms of difficulties of, when we look at the difficulties of activities of daily living, we found that in terms of mobility, there was a majority of patients who did not have difficulty with activities of daily living. However, 27% of both males and females experienced some difficulty in this regard to their mobility. With regards to pain and discomfort, there was a slightly higher percentage of females who reported pain and discomfort than females than males at 25% versus 17%. And in terms of the ability to perform self-care, males felt that they were better able to look after themselves relative to females, albeit a very small percentage. Finally, when we looked at anxiety and depression, females reported higher rates of anxiety and depression than males at 34% versus 22%. If we look at how some of these activities of daily living change following the acute illness, we can easily see that for the vast majority of patients, there was no change in the ability to see, hear, walk, remember, or even look after themselves. But when you look at the smaller values at the bottom of the table, over 20% of patients felt that they were less able to walk than they were before they became ill. 17% of patients reported difficulty in remembering in both terms of long-term and short-term memory. Nearly 10% had difficulty seeing after their acute illness. 5% struggled to look after themselves by washing, changing, or feeding. And 3% now experience some difficulty in hearing. Patients were then asked how they perceived their health on a scale from 0 to 100. We have simplified the scale from 0 to 10, where 0 was the worst health that the patient could imagine, compared to 10 being the best health they could ever experience. Please note that there were no responses for perceived health score of 0, hence why it is missing from this figure. That being said, most people reported a health score of greater than 8, which is ultimately a very good thing. Although 60% of females and 50% of males reported a health score of less than or equal to the value of 6, which lies towards the bottom end of the scale, which is somewhat concerning. In terms of fatigue intensity, patients were again asked to rate their level of fatigue on a scale of 0 to 10, where 0 was no fatigue experience compared to a level of 10 being the worst fatigue they have ever experienced. A large proportion of patients reported a level of 0 and experienced no fatigue, whilst 38% of females and 37% of males reported a level of fatigue greater than or equal to 5. When patients were asked to compare their level of shortness of breath from before they became ill with COVID to the level of breathlessness now, there was a noticeable change. Patients who reported that they had not been troubled by breathlessness, except for on strenuous exercise, dropped from 91% to 59% following COVID-19 illness. Patients who reported that they became short of breath whilst hurrying or walking up a slight hill increased from 2% to 17%. Patients who reported that they had to walk slower or had to stop to catch their breath because of the breathlessness increased from less than 1% to 10%. Patients who stopped for a breath after walking 100 meters or a few minutes on level ground also increased from less than 1% to 7%. And finally, patients who reported that they were too breathless to leave the house or perform activities of daily living increased from less than 1% to more than 2%. In the same area of discussion with regards to how patients felt in terms of their breathlessness and fatigue after COVID-19 infection, 33% felt that they were worse off than they had been previously. Finally, looking at the lifestyle changes, the majority of patients enrolled in the study reported that they were working full-time before COVID-19. Looking at patients' occupations after COVID-19, nearly 10% reported that they were doing something different to what they had been doing before. And unfortunately, we haven't been able to analyze exactly what that is at the moment, but we're hoping to have some interesting results soon. It is also important for us to consider that we don't only look at COVID-19 as the only reason for changing occupation during this extremely difficult time. Finally, something interesting, when we ask patients about their social habits such as smoking, drinking alcohol, eating healthy food, and performing physical activity, we found that about 3% of smokers were doing it less. Nearly 21% of patients were consuming less alcohol, although we may need to consider the effects of lockdown on this figure. And amazingly, 49.7% of patients reported they were eating healthier food, but unfortunately, 21% of patients were, although 21% of patients were exercising more, 30% of patients were exercising less. So what next for us and for PASIX? With regards to our current standpoint, we need to develop guidelines and train all healthcare professionals to adequately maintain and provide management for these patients who develop PASIX. We'd like to form a strong collaboration with the National Department of Health, the media, and all advocacy organizations, including health messaging on the importance of PASIX and its identification. We have the Your COVID Recovery website, which I'll discuss shortly, and inform members of the public, improve enrollment in studies such as ourselves and those to come after, as well as to plan for healthcare services and needs for patients with PASIX. Virtual consultation is also something we also need to look into with that regard to increase our reach. And with regards to our own project expansion, we'd like to conduct our surveys with a non-hospitalization as a good comparative group. And also we've considered self-assessment online questionnaires, although we have concerns about reliability of the data entry in that regard. As I noted previously with regards to Your COVID Recovery, this is currently a platform that has been developed in the United Kingdom under the NHS, which is led by Professor Sally Singh. They aim to provide a public platform to address acute and long COVID or PASIX questions for members of the public, with sections under what COVID is, what the background of it is, how it can affect you, what to do after an admission to hospital or even intensive care, guidance with regards to patients' well-being in terms of eating well, sleeping well, getting moving again, how to manage patients with family, friends, and carers, and dealing with grief and bereavement, as well as the road to recovery, from coming home from the hospital to going home, from managing activities of daily living and returning to work, as well as when to seek help and what to do next. We are currently in the process of setting up our own Your COVID Recovery website in partnership with the team in the United Kingdom, and hopefully that'll come out soon. Finally, I'd just like to say thank you and make acknowledgements to all of our wonderful team, from our research assistants to surveillance officers, as well as everyone at the NICD and the DATCOV team. Significantly, the ISARIC team has been wonderful and helped us significantly with setting up our database and giving us guidance into the topic, as well as our founders from the Bill and Melinda Gates Foundation. If you have any questions, I'll be happy to answer them now. But thank you very much for listening, and I really appreciate your time.
Hi, Murray. Thank you so much. I'm going to ask, I've got a question here from the person I'm going to introduce, and her name is Rita Viviers, and she is the chairperson of the MECFS Foundation or group. So I'm going to give her permission to come in. I feel like a school teacher. If I can find the right button, she can have permission to come in and make a comment from the survivor of chronic fatigue syndrome. And she's also got a question. Can you come in, please?
Yes. Can you hear me?
Yes, well done.
Okay, great. Thank you for the opportunity. My name is Rita Viviers. I founded the MECFS Foundation after I developed MECFS 18 years ago. I also had COVID in January with my husband, and funny enough, I have cancer, and I sailed through COVID, and he didn't. He's actually a post-COVID person. I found your presentation extremely interesting, Dr. Dryden. I'm so grateful because from our side, we're busy developing material. We've made contact with the Gauteng General Practitioners Collaboration, specifically to say what we've learned from ME, which is mostly a post-viral fatigue syndrome, and specifically in terms of the management. And it would be actually great if I can maybe outside of this forum make contact with you. I think we've got so many points so many common ground. And we've been doing quite a lot of work already, and it really fits into what you are talking about.
Yeah, we can definitely make contact outside.
That would be fantastic.
Yeah.
Thank you. I just had one question. Yeah, sorry, Vicki.
Go ahead with the question.
Yes, sorry if I've missed it. Are all your participants hospitalized? Were they all hospitalized?
So all of our participants have been hospitalized, and we've captured their information from the DATCOV hospital surveillance system. We have over 600 hospitals enrolled, both private and government hospitals, with, I can't even remember the exact numbers. Dr. Jassat will probably know better than me, but over 200,000 patients that we've admitted. I think it's close on 300,000 now. And we're extracting our patient lists from that database. The reason why we're doing that is primarily we're a relatively small study. It's a very, very small team. That being said, we are very interested, and it's not that we're not interested, it's primarily just with regards to resources that we're not looking at patients who weren't hospitalized. We actually had a discussion this morning. We've been given the opportunity to expand it to potentially enroll patients that weren't hospitalized with mild disease, which we think will be really important, so that we have a comparative group that we compare patients who were hospitalized with most likely moderate to severe disease compared to patients who had milder disease or even completely asymptomatic. So
yeah, that would be very fantastic.
Yeah, so it is primarily with regards to resources and logistics. It's not at all because we're not interested at all. It is something that we are very interested in, both from our side with the research we've done so far and our own curiosity. So it's not a matter of we don't want to. We
Yes,
definitely,
I understand.
we just,
Yes.
just need resources to do it.
Because the way I understand it from overseas research is that, funnily enough, the people going on to be sick for longer periods are actually the ones who haven't been hospitalized, who had it mildly.
Yeah,
So it will be very interesting to see what you find if you get to that.
So it is, a lot of the studies we've been reading and looking through, they actually haven't found any correlation between severity of disease. They've found that it's across the board. It can be anyone who were completely asymptomatic to someone who needed 60 days of ICU. So we don't have a definitive answer in that regard. And obviously, as the research becomes more involved, and I keep getting papers every day and new stuff keeps coming out, we'll learn more.
Wonderful.
And it is a bit of a letdown that we don't have that population already that has mild disease that we can enroll. Because it, as we said, is very important. It's very interesting to see whether asymptomatic patients versus someone who needs ICU and a ventilator are more likely to get COVID or long COVID in comparison.
So we might be able to help a little bit with that. So I'm really going to talk to you. Fantastic.
Yeah.
Thanks, Rita, so much.
Thanks, Vicki.
I'm so glad to see you up and about and with all your stuff and still going. So I'm also a chronic fatigue. Hello, my screen.
Yes.
Gone up. I think my screen has just gone off the blink here. I think it must be. There we go. It's popped in. So sorry, I was in the dark, literally. Murray, what you are saying to us, you mentioned BMI, and across the board, we seem to be linking BMI, which means body mass index, which means obesity and overweight. We seem to be seeing that. We seem to find that obesity plays a major role in all of this. Is that a comment that you would be seeing, supporting?
So looking predominantly at acute COVID illness, we've actually been doing, we've got two research projects. The one is looking at non-communicable diseases and hospitalized patients. And interestingly, in the research and the literature there, BMI does come out quite significantly in terms of odds ratios and risk ratios for ICU admission, increased risk for hospitalization, increased risk for invasive mechanical ventilation. So if I'm entirely honest, based on that, I'm not entirely surprised that we're finding that BMI is coming out in patients with post-COVID, although again, it is a very weak statistic that we have in terms of high BMI. We do need lots more literature and lots more data to look at how BMI does affect your development of post-COVID syndrome, whether it's PASIX or long COVID or any of those things. But it is, I think overall BMI does increase your risk quite significantly for firstly being admitted to hospital during an acute COVID phase, as well as developing long COVID in the end, or PASIX, sorry.
So thank you. That I think that we're all very concerned about the majority of people who have COVID and never make it into the hospital to be counted. First of all, we don't really get that until maybe later, and obesity is not necessarily routine data collected. So I mean, we people living with NCDs are used to not being counted, and so we are very grateful for your studies. We just hope it changes the whole way in which we're viewed from.
Yeah.
And then finally, what I hear you also saying is that that I'm calling it long COVID, not PASIX. Is that how you say it?
That's a very good question. We're not actually sure. So it's I've been working on it since October. So every time I talk about anything, I just call it long COVID because it's a little bit easier than rattling off an acronym. But officially, I think the terminology now is post-acute sequelae of acute SARS-CoV-2 infection, or PASIC. Obviously, there will be different variations and pronunciations from South Africa to the UK and United States and all of that sort of thing. I hope I'm saying it right. They were teasing me beforehand that potentially I might be setting the standard for the entire country, which is a bit daunting, but nonetheless, that'll be cool. But yeah, so it is almost interchangeable. It was called long COVID for a long time, and then I think it was in about end of January towards the beginning of February that the National Institute for Health in the United States, they came out formally and basically put forward the formal name of post-acute PASIC. Yeah, along that lines.
Amen.
I think people will still be using long COVID and long haulers. Even long haulers is a very general public term and layman's term that people are using, which is great, and people must use it. And as I said, if you go onto any website, whether it's Google or PubMed, and you look for long haulers or long COVID or post-acute COVID or any of those things, you're going to find papers on it. And it's just a matter of accepting that all of those are relevant and trying to put them into one group and acknowledging them as one group, and we can go from there. The more data we have, the better.
Well, thank you so much. I think those of us who live with multiple NCDs or have had, I call it chronic fatigue syndrome because it's a hell of a lot easier than all the other stuff, are used to having all this fog around us, not just in the brain, but around our diagnoses. And just to finish off, Murray, thanks for such an interesting presentation. I wondered if we could also ask the question, and now I'm having a complete blank out. Oh, I know what it was. It's about a viral disease causing a non-communicable disease. So what you're describing is something like the virus that causes HPV, the causing cancer. You're talking about the same thing about the hepatitis B vaccine virus that causes cancer complications and liver failure. So are we talking about a similar kind of syndrome? At the moment, we just are measuring it in terms of sort of symptomatic stuff, but we're talking about a chronic condition coming from a viral infection. Is that it?
So I don't think at Liberty I could definitely say, yeah, it's going to happen, or no, it's not going to happen. I think it's still very early. As much as we've had people talking about long haulers since February last year, a lot of the clinical research that's been going on and happening has been predominantly focused on acute management of patients and making sure that patients die. And it's now where people are either waking up to it and they're actually thinking, okay, long COVID is something we really need to look at and we really need to start thinking about, or they've been doing that, they're just starting to publish their results at the moment. As I said, we've been going since January. We still haven't even looked at publishing results at the moment because we're trying to get a good sample size. There are some samples where they've got less than 1,000 patients, and we've only just reached 1,000, and we don't feel comfortable publishing that. We don't feel that the analysis will be good enough and we'll get good statistics from that. So in terms of COVID going on to cause other diseases and other non-communicable conditions such as hypertension or diabetes or cardiovascular disease or cerebrovascular disease or even neoplastic disease or cancer, we don't know. We'll unfortunately, we need to keep putting our nose to the grindstone and keep looking for everything and keep watching patients. We can't let things slip and fall behind. And ultimately, we'll just have to keep watching patients. And this is why we need things like public information. We need the data to go out. We need patients to be aware of what's going on and know that we're aware that this is happening and we are watching it and trying to see what's happening. And ultimately, what we need is we need buy-in from all departments of health, whether that's national, provincial, district level, or whatever. We need the members of the public to buy into it and have the information readily available to themselves and feel that they can present to the doctor without being concerned. And we can go from there and investigate them as necessary, when necessary, and do as much research as we possibly can so that we can help prevent and manage patients who do go on to develop it, unfortunately.
Thank you so much. I'm now abusing everybody's time. Thank you. I've got lots of thank yous if you look in the chat box before we go off. Thank you to Rita for joining us and adding value to our chain. And we meet again next week on the next Thursday, and we will be looking at children, vulnerable children, and looking at people with disabilities and COVID and how do we move with that. And you're all welcome to join again. And thank you so much, Waasila, Murray, everybody here. We're so grateful. Thank you so much. Bye-bye, everybody. And I hope all the Emmanuel Petersons are happy today because there's a hell of a lot of you there. Bye-bye. Thanks, Murray.
Bye.
Bye.